Singh, your host for this webinar. I know that today's topic might bring up a number of questions from you. So you may type your questions in chat box, and I want to let you know that we will address as many as we can in the time we have today. And I welcome and request our NBMS National Webinar Coordinator, Professor Dr. Somashekar, to start this session. Thank you, and over to you, sir.
Thank you very much. Dear trainees, welcome. Very good morning. Take my word, this is one of the most recent article which I read in last 3 months, which was extremely difficult for me. Way back from 1999, I have been reading the seminars in surgical oncology, especially the special chapter which Japanese group authored about the visceral layer, parietal layer, the nerves, and various types of anatomy. But no other article I saw which deciphered line to line, fiber to fiber, bundle to bundle, the exact anatomy of the external sphincter, internal sphincter, and its relevance to intrasphinctic resection in very low rectal cancer. So finally, if you see the title of this paper, it is not rectal sphincter, anal canal with functioning nerve and sphincter. It's a beautiful paper, and I know two very senior people, Dr. Sharad Bhai, he was my senior at GCRI, excellent surgical oncologist, very academic, great surgeon, down to earth good human being, always has passion for teaching, who brought IASO to great heights. And then Kalai, great friend of mine. More than that, he's a perfectionist. He doesn't close the abdomen or remove the robotic port unless the surgery is done the way he wants it, the right way. And he has read this article extensively well, and line to line he is aware of it. This is a very tough but most important article to understand for every surgical oncologist who is going to graduate. We have over 300 DNP surgical oncologists now on this platform. I know around 300 login, first year, second year, final year. And Dr. Syed Shujat has volunteered to decipher this very tough article. Congrats, welcome, Sujat. I know you're always ready to take part in teaching program of DNB National Board. So thank you very much. I thank Sharad and Kalai Saran. Kalai Saran is the head of department, professor of GI surgery from JIPMA. Sharad Bhai is a senior most surgical oncologist and a very active senior most top official bearer of IASO from Neeraj. Over to you, all of you. Please listen this. They will analyze it, ask your question and answer in Q&A box or chat box at the end of it. So over to you, Shujat.
Yes. Good morning, everyone. In today's Journal Club, we'll be discussing this review article, which was titled Anus Preserving Surgery in Advanced Low-Lying Rectal Cancer, a Perspective on Oncological Safety of Intersphincter Resection. So, before getting into the article proper, let us see what is the background. Surgery for rectal cancer has come a long way, starting from Miles' APR procedure, which was the initial description for rectal cancers, and which was indicated for all the regions of rectal cancer, that is the upper third, middle third, and as well as the lower third cancers in the initial days of rectal cancer, to the recent ones of Hojo and Moriwa's nerve sparing TME procedure. So because of these surgical developments and surgical innovations, APR is currently and was essentially limited to only low-lying rectal cancers. Latest in this series of surgical innovations in rectal cancers is intersphincteric resection. This was first described by Schiesel in 1994, again meant for a subset of patients with low-lying rectal cancers, again snatching away some of the patients of low-lying rectal cancers from APR procedure. So we have come a long way. On the left hand side, we can see it is the APR procedure which was described initially, to the picture on the right side, which shows the description of intersphincteric resection. So intersphincteric resection, it is nothing but here we remove the rectal cancer in the intersphincteric plane. I mean, including the internal anal sphincter, but preserving the external anal sphincter as well as levator ani muscle complex. So this is the review article which we are going to discuss today. This was published in Korea in September 2020, published from Korea in September 2021 in Cancer's Journal. Coming to the background, so we all know that rectal cancers were not surgically resected till the 19th century, Only in 1826, Lisfranc first described rectal cancer resection. What he had done was he had amputated the rectum without any anastomosis. Next came the Miles procedure, which is akin to the radical mastectomy in case of breast cancer. He was the first one who described the abdominoperineal resection. But as we all know, he had very high recurrence rate of around 40%. Then the next important milestone was the Claude Dixon's anterior resection. This was one of the few procedures. This was one of the first procedures where the anus was spared. Then came the low anterior resection, where again this was described for middle third rectal cancers, and he was the first one who had described the coloanal anastomosis, again sparing the anus. So these were the series. These were the surgeons who had described that anus can be preserved in case of rectal cancers. Next, the coloanal anastomosis was simplified with the development of surgical staplers, and which was again made easy with the development of double stapled anastomosis. And next came the very important milestone in case of rectal cancer surgery, which was the development of TME described by Bill Hild in case of 1982. So this is now intersphincteric resection is the latest in this rectal surgery innovation. So intersphincteric resection followed by hand-sewn coloanal anastomosis is the ultimate anus preserving technique. This provides the benefit of avoiding a permanent stoma, and this has changed the concept of anal preservation, and since 2000 has rapidly expanded not only in Europe but also in Japan and other Asian countries. So intersphincteric resection for low rectal tumors was initially described by Shizel et al. As described earlier. So what we do in this is we preserve the external anal sphincter as well as the levator muscle complex while removing the rectal wall, including the internal anal sphincter, and followed by coloanal hand-sewn anastomosis. So what is the classification of intersphincteric resection and patient selection? As we can see in this pictorial diagram, the purple one is the resection line for the first type of the intersphincteric resection, called as the partial intersphincteric resection. Here we resect the distal resection margin would be at the level of dentate line, and we would remove the internal anal sphincter only partially. Next one, the below one, the blue one is the subtotal intersphincteric resection, where along with the removal of internal anal sphincter subtotally, but the resection, the distal resection line lies between the level of dentate line and intersphincteric groove. Whereas the total, in case of the total intersphincteric resection, the resection line lies at the level of intersphincteric groove, and here we remove the internal anal sphincter completely. In all the three cases, we preserve external anal sphincter as well as the levator muscle complex completely, as opposed to the APR procedure. So the choice of dissection line depends on the lower border of the tumor in order to obtain an adequate distal dissection margin of at least 1 centimeter. This is important as we need to know that the distal dissection margin should be at least 1 centimeter, as in other cases of low rectal cancers as well. So what is the patient selection criteria? The indications include well or moderately differentiated low-lying rectal tumors, T1 to T3. This is really important. T1 to T3 tumors are the ones who are going to be taken up for this procedure, lying within 5 centimeters of anal verge, independent of internal anal sphincteric invasion. So what are the contraindications? These include poorly differentiated tumors, T4, that is fixed tumors at digital rectal examination with external anal sphincter or levator muscle infiltration, and or untreatable distant metastasis. Apart from this, other contraindications include poor anal function, severe medical comorbidities, or psychiatric disease, because here we are going to preserve the anus anal sphincter complex, and mental competence is really required to post-op rehabilitation. So we have another selection criteria described by Roulier et al. This was MRI-based classification. In this, he had described low-lying rectal cancers into 4 types, in which the type 1 was the low-lying rectal tumor is more than 1 centimeter away from the anorectal angle. In the type 2, the rectal cancer, the lower border lies within 1 centimeter of the anorectal angle. In case of type 3, here there is the low-lying rectal tumor involves internal anal sphincter complex, and in case of type 4, the tumor involves the external anal sphincter as well. So the intersphincteric resection is mainly indicated for type 2 and type 3 tumors, whereas for type 1, ultra low anterior resection is indicated, whereas in case of type 4, ideally APR is indicated. But few studies also have described, some authors have also proposed to combine intersphincteric resection with partial resection of the external anal sphincter also, depending on the region of involvement for type 4 tumors as well. But this is not endorsed by all the authors, or else the intersphincteric resection also can be extended to these patients also, that is type 4 patients also, if they are downstaged after neoadjuvant CTRT as described by Park et al, and the poor responders are excluded and they undergo an APR procedure. So what are the margins that we should have in case of intersphincteric resection? First we'll describe the distal resection margin. The proximity of very low rectal cancer to the anal sphincter raises a specific problem, that is how and until when can we preserve the anal continence without compromising the oncological safety. The radical solution offered by the APR was the historical choice option for these tumors, in particular to ensure the distal and lateral safety margins. So the recent developments where they have said that the margins can be minimized have helped in the development of this technique. So initially, the general belief was that an adequate resection required at least 5 centimeter distal resection margin, but research results showed that lymphatic spread was limited to the level of tumor or higher up within the mesorectum, with a local spread present only in few millimeters laterally. This was described mainly by the Golligher et al. In 1951. So the recent studies have shown that levator ani muscle, external anal sphincter, rectal tissue, and perianal skin are rarely involved by rectal tumors, even when poorly differentiated, and that the intraluminal and mesorectal spread rarely exceeds 1 to 2 centimeters. Hence, the DRM cutoff was reduced to 1 centimeter with or without preoperative neoadjuvant chemoradiotherapy. This was described mainly by Moore et al. This 1 centimeter cutoff was again validated by the study from the Norway, who had studied around 3,500 patients, and they reported a negative impact on tumor recurrence when the distal resection margin was reduced to less than 1 centimeters. However, during ISR, the surgeon's goal is to provide a macroscopic distal resection margin of 1 centimeter. However, a distal resection margin below 1 centimeter is considered safe by some authors at the final pathological examination if the margin is free. We should remember that formaldehyde fixation reduces the distal resection margin by up to 57% after 12 to 18 hours of fixation. Therefore, it is important to always consider the DRM on fresh specimen for surgical reports. Now, coming to the question of circumferential resection margin, the mesorectum in the low rectum is very thin or nearly absent, and an invasion of external anal sphincter, levator ani muscle complex, is considered a technical contraindication, with only a few authors advocating for a partial EAS excision along with the intersphincteric resection only in specific cases. The CRM cutoff, however, for intersphincteric resection is same as for the standard proctectomy, that is at least 1 millimeter, more than 1 millimeter margin should be there. So how do we assess for CRM preoperatively? Intersphincteric plane clearance is assessed by preoperative rectal MRI and digital rectal examination, both at the time of clinical staging and before starting surgery, in order to assess tumor mobility and tumor relationship to the anal sphincters. The slicing method performed by the pathologist also is crucial for CRM assessment. Longitudinal slicing is recommended method as opposed to the transverse slicing method for CRM assessment. So to describe the completeness of intersphincteric resection, there was this concept of TILME was developed on the lines of TME. So ISR is considered as a longitudinal extension of a beyond TME procedure. So on the lines of TILME was described by Kim et al. And the quality was based on the completeness of longitudinal muscle excision of the rectum, including the two principal items to classify as incomplete TME, that is longitudinal muscle of the internal anal sphincter complex. The defect should not be more than 5 mm and the CRM should be more than at least 1 mm. So if these two criteria are not met, then it is considered as incomplete TILME. TILME is nothing but total internal longitudinal muscle excision. And now coming to the anatomy of deep pelvis, this is really important, as we all know that the complete TILME should be done. So we'll go through what is the anatomy, as the sir had described that this is really an important part of this article. So intersphincteric dissection is an anatomically planned technique carried out in the intersphincteric plane with specified, well-described steps and anatomical landmarks. First, we'll see what is the posterior anatomy. So this was the initial anatomy, as we all know. This was the gross anatomy, but now due to the extensive cadaveric dissection, now we have got to know what is the microscopic anatomy. So this is the microscopic anatomy, which is recently described as, and this is really important that we should know. So this is the circular muscle of the rectal canal extending into the anal canal. Uh, The circular muscle of the rectal wall, after going down into the anal canal, transforms into internal anal sphincter, which is enveloped externally by the longitudinal muscle. This LM is longitudinal muscle, and external to the longitudinal muscle, we can see we have the levator ani muscle extending downwards and transforming into external anal sphincter. They are both contiguous structures, levator ani muscle and external anal sphincter. And the intersphincteric plane lies outside the levator ani muscle, and we should preserve the levator ani muscle and external anal sphincter complex. What is really important to understand in this figure is the longitudinal muscle gives extensions into the while going down. The first extension is called as the hiatal ligament, which connects the levator, which connects the longitudinal muscle to the coccyx. So this one, the HL is the hiatal ligament. The another extension of longitudinal muscle is into the subcutaneous tissue of the anal skin, perianal skin, and it also gives extension posteriorly, which again goes back and joins the posterior aspect of coccyx. That is called as the anococcygeal ligament. So the extensions of longitudinal muscle is important, and the intersphincteric plane lies outside the levator and longitudinal muscle, but inside the levator ani muscle external anal sphincter complex. So while doing the intersphincteric dissection from above, we should know that we have to divide the hiatal ligament, which is nothing but the extension of the longitudinal muscle, which connects the longitudinal muscle to the coccyx. We divide the hiatal ligament, go into the intersphincteric plane between the longitudinal muscle and levator ani muscle, and in the perineal phase, we again we start from the intersphincteric groove and enter the plane between the longitudinal muscle and external anal sphincter complex. So the intersphincteric plane is located between the outer surface of longitudinal muscle and the inner surface of external anal sphincter. The hiatal ligament is the surgical landmark, important surgical landmark for posterior region of the deep pelvis, and has to be dissected close to the posterior aspect of rectum to access the posterior intersphincteric plane. Now coming to the anterior anatomy, this is different both in case of males. This is different in males and females. As we can see, the picture on the left describes the anterior anatomy in case of males, and picture on the on the right hand side describes the anterior anatomy in case of females. First, we'll go through the male anterior anatomy. Here again, we can see the circular muscle is enveloped by longitudinal muscle, but here the extensions of longitudinal muscle is quite complicated. Again, this gives three extensions. One extension is given anteriorly. One extension is given anteriorly into the urethra, which goes and joins the membranous urethra, that is the rhabdosphincter of the membranous urethra. The other extension of the longitudinal muscle goes down and in front of the external anal sphincter and behind the bulbospongiosus muscle. And the third extension goes down along the normal path of its course. So here the development of intersphincteric plane is quite difficult, as we all know, as we can see that there is no actual plane between the longitudinal muscle and the rectourethralis muscle. So we have to divide the rectourethralis muscle in order to go into the plane between the longitudinal muscle and external anal sphincter. So this is really complicated in case of males. And in first we'll go through what is the plane in case of female anatomy. Here again we can see the RVS is the rectovaginal septum. The plane higher above is clear. As we can see, we have a clear plane between the vaginal mucosa and the longitudinal muscle. But as we go down, we have the longitudinal muscle intermingling with the smooth muscle fibers of the vaginal mucosa. So this area is the intermingling of the longitudinal muscle and the vaginal smooth muscle fibers. So again, while coming down, we don't have any clear plane anteriorly in the anal canal. But as we come down in the extreme lower part, again, we do have a plane between the external anal sphincter and longitudinal muscle complex. So So the intersphincteric plane is not clearly evident in the anterior region in both the genders, but can be found through two anatomical landmarks. In males, the anterior dissection is performed along the denon-villus fascia, which that is crucially and it is dangerous area during dissection. In females, the rectovaginal septum and the anterior dense area of muscular intermingling are the surgical landmarks to go into the intersphincteric plane. Because the anterior region misses a clear surgical plane, the anterolateral region of the rectum should be previously dissected to optimize the anterior dissection during intersphincteric dissection. So now coming to the lateral dissection, the lateral anatomy, as we can see on the picture on the right, we can see there is a clear plane between the longitudinal muscle and external anal sphincter complex. And we divide again the hiatal ligament and enter into the intersphincteric plane between the longitudinal muscle and external anal sphincter and come out through the intersphincter groove in the anal verge. And we decide upon the distal resection margin depending upon the lower extent of the rectal tumor. So the surgical landmark for the correct lateral dissection is the plane found between the medial edge of the levator ani muscle, external anal sphincter, and the longitudinal muscle. So this summarizes the all the three aspects of the anatomy. As we can see on the left top picture, it has described the posterior dissection. We go in the TME plane in the correct intersphincteric plane outside the longitudinal muscle, and laterally again we go in the intersphincteric plane outside the longitudinal muscle. The crucial part is the anterior dissection, both in case of males and females, where there is no clear distinct intersphincteric plane. Now now as once we have understood the anatomical aspects of the intersphincteric dissection, now we'll go through what are the surgical approaches for this procedure. So as compared to open procedure, laparoscopic resection is technically challenging. It has steep learning curve, but it has improved early postoperative outcomes, and it is oncologically safe with no differences in disease-free survival or overall survival. When we compare open with robotic procedures, robotic has better ergonomics with a magnified stable view, and it allows extension of abdominal phase, thereby reducing perineal time. So this is really important that robotic surgery and robotic platform allows us to extend the abdominal phase resection into the intersphincteric plane, and it reduces the perineal resection time. So what are the studies? What have the studies shown? When the studies which have compared open versus laparoscopy, laparoscopy had less blood loss, shorter length of post-op hospital stay, quicker time to first flatus, less incidence of morbidity and pneumonia, and with comparable pathological and survival outcomes, and it has comparable operative time as well. When what have the studies said on the robotic surgery? The robotic intersphincteric resection had 5 years cumulative rates of local recurrence of 2.5%, with overall survival of 86% and DFS of 87%, 80% described by Kim et al. Again, this is really comparable to the open procedure. Now, comparing the robotic versus laparoscopy, robotic surgery had lower conversion rates with lower estimated blood loss, but it had longer operation time compared to laparoscopic intersphincteric resection. Other perioperative outcomes, including the functional outcomes, 3 years survival, and local recurrence rates were statistically similar. The limitations of these studies were that only retrospective studies were included, and these included East Asian studies. And the East Asian surgeons are very well versed with laparoscopic surgery. Hence, the difference between robotic and laparoscopy was not enhanced in these studies. So there are few advantages of the robotic platform that it offers. This was described by Kim et al. The robotic approach was reported to be the most significant parameter for intersphincteric resection achievement, with higher rates of advanced intersphincteric resection. As we all know, we need to have a magnified view to enter into the correct plane. As we all know, the anterior dissection is not well defined in both the genders. So the magnified view, the robotic platform that it supports helps us really well. There was no difference in pathological stage, histological differentiation, distal dissection margin, and CRM positivity. Perioperative outcomes were superior in case of robotic intersphincteric dissection with lower blood loss, lower post-op pain score, lower voiding difficulty, lower permanent stroma retention, and lower fecal incontinence score. Recently, single port robotic intersphincteric dissection also has been described, but the studies are still awaited. So it is important that the surgeon rethinks the anatomy of the deep pelvis through the eyes of a pathologist, and this is possible with the enhanced view allowed from the robotic camera. This allows microscopic anatomy to be seen by experienced surgeons as macroscopic anatomy. So what is the impact of neoadjuvant chemoradiotherapy on intersphincteric resection? NACTRT allows for downstaging, a reduction in tumor deposits, budding, and macrometastasis also. Neoadjuvant chemoradiotherapy is a standard treatment to reduce positive CRM and local recurrence rates in locally advanced rectal tumors, according to NCCN guidelines. Initial concerns were for advising ISR to patients with infiltration of external anal sphincter levator ani muscle complex with tumor shrinkage after neoadjuvant chemoradiotherapy. But the studies from Park et al. And POZ et al. Have shown that APR can be advised only for non-responders, and those patients who respond and have downstaged after neoadjuvant chemoradiotherapy, intersphincteric dissection also can be offered to these patients as well. So what are the oncological outcomes? So there were various studies that were carried out to see the oncological outcomes of intersphincteric dissection, as we have reduced the distal dissection margin as well as the circumferential dissection margin. So as we can see from the bottom row, the R0 resection was around 96%, which is really high, with local recurrence rates of around 6%, which is comparable to the TME procedures of the other rectal cancers, with distant recurrences of around 17% and 5-year overall survival of around 90%. So there were few studies who looked at what are the risk factors to improve oncological outcomes, and these were studies mainly from Korea, and they have described that is the YPT stage, YPN stage, preoperative CEA levels, and circumferential resection margin status and tumor size are the prognostic factors. Are the prognostic factors in case of low-lying rectal cancers and undergoing intersphincteric resection. So there were few studies who had compared intersphincteric resection versus abdominoperineal resection, and they had concluded that there was similar local recurrence rates of around 11%, with disease-free survival of around 70%. In these studies, GRECAR-1 trial is really important. This demonstrated the feasibility of safely changing an initial APR indication to anus sparing resection, such as intersphincteric resection, according to tumor response to neoadjuvant chemoradiotherapy, as was described by Park et al. And POZ et al. Now, further extensive multi-center studies are needed to confirm the GRECAR-1 results. So the both the procedures have similar oncological outcomes, but better functional outcomes in case of intersphincteric resection. So coming to the functional outcomes of intersphincteric resection, so this is really important to understand in oncology as well as in other surgical procedures. It is not what you have removed, but what you have left behind. So as we all know that the levator ani muscle and external anal sphincter complex mainly contributes to the squeeze pressure of the sphincter, whereas the internal anal sphincter contributes to the main resting pressure of the sphincter. So there were few studies who had looked at the functional outcomes of intersphincteric procedure. First one among these was Denost et al. He had said that the patients who had undergone intersphincteric dissection had 42% major Last syndrome with 25% of moderate incontinence and 44% major incontinence. That means around 60 to 70% patients had around a moderate to major level of incontinence following intersphincteric dissection, which is high, but this comes down after 2 years and postoperative appropriate rehabilitation. Overall, 12% only 12% patients required definitive stoma. Kim et al. Also had looked at the functional outcomes, and his study had given three important inferences. There were no differences in mean fecal incontinence score between partial and subtotal intersphincteric dissection, but there was difference in these scores between total and partial or subtotal intersphincteric dissection at 12 to 24 months follow-up, confirming a significant functional worsening after complete excision of the internal anal sphincter. This means that internal anal sphincter should also be preserved as much as possible after having adequate distal dissection margin. The second inference was maximal tolerance volume and urge to defecate volume were not different between subtotal or total ISR, confirming that preserving dentate line also as much as oncologically possible is clinically relevant. So here comes the classification of intersphincteric resections, and we should do only what is required. The third inference was partial excision of external anal sphincter did not influence the manometry values except for mean resting pressure, which is as we have seen mainly dependent on the internal anal sphincter. Further standardized multi-center studies should be performed on a large number of patients to better understand the functional outcomes with care on separating hand sewn from mechanical coloanal anastomosis techniques and on evaluating each ISR type. So there were few studies who had looked at the patterns of local recurrences following intersphincteric resection. And these studies have shown that lateral recurrences are more common than central recurrences. And Saito et al. Had reported an intricate relationship between the anorectum and the pelvis. And these routes could be possibly responsible for local recurrences even when CRM involvement was negative, reinforcing the role of lymphovascular invasion as an important risk factor. So this study outlines the need to better standardize the intersphincteric dissection technique and to better patient selection. Future multi-center studies focusing on the patterns of local recurrence are required to better define the indications between intersphincteric resection and abdominoperineal resection. So coming to the next aspect of this review article, that is the learning curve and surgical education. Q et al. Had studied both laparoscopic as well as robotic intersphincteric resection learning curves. For laparoscopic surgery, he had described operating time as the criteria and a technical indicator for the definition of the learning curve. And for the learning curve, he described two stages with an arbitrary division. He had described the two phases in two stages in initial 18 months, followed by next 6 months. For robotic surgery, he had described two plateaus, and the first plateau was attained after 19 patients' surgery. He also reported that a certain advanced experience in both laparoscopic and robotic colorectal surgery is required to perform oncologically safe laparoscopic and robotic surgery. Therefore, surgical training in these approaches require a higher surgical volume. And further educational videos and anatomical reviews are necessary for providing surgeons a precise knowledge of the deep pelvis, allowing them to master the ISR technique and reduce the impact of unnecessary abdominoperineal resections. So to conclude, intersphincteric resection is an oncologically safe technique and a valid alternative to APR when indications are carefully selected. Thorough knowledge of the deep pelvic anatomy is of utmost importance to perform high quality ISR. The robotic approach allows a clear anatomical identification of the dissection plane to optimize the intersphincter dissection with reported high quality long-term oncological results. Thank you.
Good, superb, extra, very good job. You did excellent. So, Kalai, will you go ahead? You have any slides to share to explain what he presented?
Yeah. So can I share, because I thought he covered.
Please share. Yeah, please share. Navneet Singh ji will guide you.
So let me show some of the videos. I think that's important because Sharath has nicely covered the anatomical landmarks. So I thought the students might understand well if you show some short video clips of maybe 30 seconds. So the first point which he has, I think you've seen my videos playing. Is the video screen seen or the other one on the screen?
Please wait. Dr. Raja, I think you have to play it again.
Okay, fine. Yes, sir. And sharing. Is it okay now?
Yes.
Yeah, we are seeing a bit.
Yeah, I've stopped it. Okay, so the first point to highlight is Sharath mentioned about the hiatal ligament. I want the students to understand this term. Hiatal ligament is used to clarify because previously some of the textbooks and also articles mentioned this as an anococcygeal ligament, and various other terms have also been used, including rectosacral fascia ligament. So multiple terms have been used. So the point to remember is why hiatal ligament is important, because that is the area. So when we are doing the posterior dissection, you will have a loose areolar plane between the fascia propria and the presacral fascia. As we reach close to the hiatal ligament, although it is called as ligament, it is actually composed of muscle fibers from the longitudinal muscle layer of the rectum. So how we realize that? You will have a nice areolar plane opening up just with the retraction. But as we reach close to the hiatal ligament area, you will start encountering the fibers. So this is what, as we are encountering here, the smooth areolar tissue is replaced by a few muscle fibers, and you need to go close to the rectum here rather than going close towards the levator muscle. Otherwise, we won't be entering into the intersphincteric plane, but we will be going into the deep post-anal space through the levator muscle. So that's the importance of knowing about this. The next is Sharath mentioned about the lateral dissection. So in the lateral dissection, the critical point is to identify the junction between the lever trani muscle and the longitudinal muscle. So we need to remember the longitudinal muscle is the smooth muscle component. Lever trani is a skeletal muscle component. So we can actually identify that by using the electrocautery, and use of electrocautery help us to identify like this contraction indicates that's a portion of the lever trani muscle. So you just move medial to that. So that is the important thing to remember when we are in the lateral plane. So identifying the junction between the skeletal muscle component and the smooth muscle component. So that is the important point to remember during the lateral dissection. Now, the most important challenge comes when we are in the anterior. So for the anterior dissection, so he has mentioned in males, it is a recto-urethralis, because that's where the longitudinal muscle gives branches anteriorly as a recto-urethralis muscle. So we need to divide the recto-urethralis muscle close to the rectum, because otherwise you'll be damaging the urethra. So once the landmark is, we see the prostate. So that's the prostate. And just underneath, you'll be going to below the prostate. So you can see these are the longitudinal muscles. This is the longitudinal muscle of the rectum, and which gives extension as the recto-urethral muscle. So the above is the recto-urethralis. So we need to give a good traction, counter traction. That itself will help us to identify the plane between the longitudinal muscle and the recto-urethralis. In the female, he has mentioned about the anterior dense tissue. So once we identify the rectovaginal septum, the plane initially will be very easy, and you'll have very thin tissue. But as you go down, you will have the intermingling of fibers between the longitudinal muscle and the vaginal muscle, which is called the anterior dense tissue. So that serves as a landmark that we are entering the intersphincteric plane. So these are the anatomical points. Just the last one more. Because when we do all this intersphincteric or ultra-low, so important to preserve the nerves. That is something which we need to identify specifically and preserve them. So we all know about, that is one point which is not part of this article. So, but we generally say that mesorectal plane is between the fascia propria of the rectum and the presacral fascia. But this presacral fascia is not a single layer. There are actually two layers. The one layer which covers the presacral vessels, and then there is another layer which actually covers the nerves, the hypogastric nerves. So that's called the Kinugasa fascia. So our plane of mesorectal excision should be between the fascia propria and the Kinugasa fascia. So that can be very well seen here. So if you see here, so these are the nerves. Now these are the nerves, and you will have a thin fascia covering that. So you should not go underneath the nerves. So the plane is between the fascia propria and the fascia which covers these nerves. So you can see here, so these are nerves, and you can see one thin fascia covering the nerve. The nerves are not lying bare, and you need to preserve that fascia and go between. So you can see here, so the nerve is covered by fascia. This is a nerve, and our dissection stays above that fascia. You can trace a nerve laterally also and preserve that fascia so that the nerves are retained. So your plane of dissection is between that the Kinugasa fascia and the fascia propria, which covers the rectum. So that will ensure the preservation of the nerves. So these are the critical points. Now we can see the full nerves. This is the hypogastric nerves dividing to left and the right, and they go. And you need to actually preserve laterally. Once you preserve laterally, and then you can trace it the anterior also. You can see here the nerves are preserved well, and then you can. So these are the points I just wanted to highlight so that the residents can understand better what Sharath has mentioned in his presentation. That's it from my end.
Sharath bhai, you want to give the comment about it before we open the chat box and Q&A and answer?
No, actually I saw videos there. I mean, he has displayed the things very clearly. Dr. Raja has done very good dissections, and the anatomy which was displayed for the students was fantastic. I think it adds on to the information which was already given in through the journal. I think we can open the topic for discussion now.
Okay, students needs to understand year 2000 seminars in surgical oncology, there was a special issue brought on anatomy of the rectal cancer and the nerves. The VLPF, PLPF, parietal layer of pelvic fascia, visceral layer of pelvic fascia, and the anomalous accessory middle rectal in 23% on the lateral side, and how to do a type 1, type 2, type 3 TME, and what is space 0, where the nerves and between the mesorectum is there, space 1, where the ureter and gonadal is there, space 2, where you do LLND is explained. Please go and read that very much, or you can visit my YouTube. I have about 110 videos and a full lecture based on the seminars in surgical oncology and the rectal cancer I have put. But this particular paper actually adds very well what should be the intersphincteric. So Kalai and Sharad, will you open both Q&A and chat box and take each question? And at the end of it, I want both of you to answer two things. What are these terminology? Anterior resection, posterior resection, LAR, ultra low LAR, intersphincteric, and what are the steps we need to take to prevent anterior rectal syndrome? So first, both of you can open Q&A and chat box both and take each question and answer them.
Yes, I think the first question is on how to prevent the necrosis at the level of anastomosis. That's an important point today because in ISR, the level of anastomosis will be just 1 centimeter from the level of anal verge, maybe 1 to 2 centimeter at the most. So you need to have a good length. The tension at the anastomosis is an important cause for the late necrosis. So we need to minimize the tension. Two important points: adequate mobilization of the splenic flexure, mobilize the mesocolic fascia from the pancreas. So that ensures you will have a good length. Second is, more than the oncological reasons, we tend to do a high ligation of IMA because when you ligate IMA proximal to the left colic artery origin, along with a high ligation of the IMV at the level of inferior border of the pancreas, you gain at least an additional 5 to 10 centimeters. This has been proven in the cadaveric studies. So these two things, the good mobilization of the colon to ensure tension-free anastomosis. And second is, you need to use ICG at the transection end to assess vascularity. That's an important, I think, Professor Somashek also has published an article on the utility of ICG. That's a useful adjunct to assess vascularity. These measures will minimize the complication related to the ischemia of the anastomosis.
So there is a question asking whether are you doing NACRT all the time? I think in today's world, free of NSCRT is the method of choice as per NCCN. Uh, before you proceed to any major rectal surgery.
Yeah, that point which was mentioned also by in the presentation, the standard indications are T1 to 3. T4 is traditionally a contraindication for ISR, but there are recent evidences which show when there is a good response after NACTRT and a post NACTRT, there is no involvement of the sphincter. You can selectively do not a standard recommendation, but I mean, that decision has to be decided on individual basis, especially if the tumor is a good or moderately differentiated. The duration of a diversion stoma after ISR, that's almost the standard what we use in other conditions. I mean, there are some recent studies which have shown that you can close the stoma maybe 2 weeks after doing this LAR or the ultra low anterior resections to minimize the morbidity associated with the stoma if the anastomosis is patent. Usually when we do stoma in ISR, we do closure maybe 4 to 6 weeks because that also allows the time for the sphincter function to recover, because manometric studies after ISR have shown there is a deterioration of the sphincter function up to 6 to 12 months, and then there is a recovery of the sphincter function. So we generally do stoma closure after 4 to 6 weeks whenever ISR is done. Coloanal anastomosis, how to prevent Lars syndrome. One point I just want to highlight here. So traditionally, ISR means you are combining abdominal with perineal dissection, which means the last portion is done from the perineum. But maybe I'll ask Professor Chomashekar also comment on that. With the robotic platform, you can go well into the intersphincteric plane from the abdomen itself. I think now we have a series of cases in which an anastomosis is done 1 to 1.5 centimeter from the anal verge, exclusively through the abdominal approach with the robotic platform, because you can very well identify the intersphincteric plane, go into the intersphincteric plane, do the dissection, and then use a suprapubic trocar, and you can actually staple it just 1 centimeter from the anal verge and complete the challenge there would be placing the stapler head. So that's a challenge. But if you can manage that, you can do the anastomosis completely from the abdominal end. To some extent, it might prevent the sphincter damage. We don't have any evidence. We are actually trying to do the manometric studies to document that. That is one point. There is also, instead of doing an end-to-end, doing an end-to-side, which has been reported in textbooks, but no personal experience, which has been shown to minimize the complicated anastomosis and also Lars syndrome. But that is something which does happen with ISR. It's a known complication which you need to explain to the patient. That I think covers the next question of related to the technique of colonal anastomosis also. As I mentioned, with the robotic platform, we do the stapled anastomosis after ISR also.
There is also a question from Santosh who has repeatedly put, sir, the distal margin in the rectal cancer we need to take is pre-NACT or post-NACT. I'll tell you why this particular question comes. Sharad Bhai can also take this. In the field of oncology, like in head and neck cancer, in spite of neoadjuvant chemotherapy, we need to still go back and resect what was seen pre. So that's why people refute in oral cancer, other than the organ preservation protocol in larynx, nasopharynx, hypopharynx. What are the use of giving neoadjuvant chemo if the margin is same? But in case of breast cancer, the margin we take is what is left behind after chemo. That is why in T3 lesions, we are able to achieve a breast conservation. If we are going to take a margin prior to chemo, then there is no organ preservation protocol in solid tumors of onco ever to be possible. So in case of breast, we use what is left after chemo, but in ovarian cancer, we go back by what it is. So it is apt that Santosh is confused. In rectal cancer, is it the pre-NACT margin or post-NACT margin? So both of you, Kalai and Sharath, can answer this.
See,
Sir,
unlike-
I see you. Yeah. Yes, sir. Please go ahead. I'll answer this.
Unlike breast cancer has got a lot of other modalities where we can treat. But colorectal cancer, head and neck cancers, all these cancers have got limit. Their main achievement is through surgery after radiation therapy. The role of chemotherapy to salvage local recurrences or metastasis is little less as compared to breast. So in such instances, we highly strong rely on surgery. So it is better to mark out, if possible, the distal margin and then plan out using the preoperative distal margin whenever possible.
That's true. Kalai, you can take that question and put your inputs also.
Yes, I mean, I agree what Dr. Professor Sharath has mentioned, but the one thing also is to remember, because in practice, when we see the patient after neoadjuvant chemoradiotherapy, in practice, actually, we go by what is the tumor which is left after the neoadjuvant chemoradiotherapy. And then, because if a patient has a very good response, it's actually difficult to know what was the margin before, unless you have some techniques to objectively document what was the previous, because we just documented based on the MRI plus the digital rectal examination. So when the patient has a very good response, so there'll be only a small induration which will be left behind. It happens, it does happen in 20% of the patients. In those patients, we go by post-NACTRT, the tumor extent, and then we use, and from that, we calculate the margin. In those patients, actually, we are doing ISR in spite of them being locally advanced pre-NACTRT. So it's not a hard and fast rule that all cases we go by pre-NACT margin. Various individual basis. In patient with good response, we actually take the post-NACTRT tumor extent for the margin.
Thank you. You know, as an exam, what you need to tell as a students. Remember, preoperatively, if a sphincter complex is invaded by the tumor at the dentate line documented by MRI, no amount of pre-op chemo RT will allow that sphincter to be preserved. The answer lies in the 3 trials from MSKCC. In the year 2003 and 2005, MSKCC trials are published. It is called as MSKCC Rectal Trial 1 and Rectal Trial 2. What they did is, in an apparent patient where dentate line and sphincter complex is free, but it is extremely close to the dentate line under 1 centimeter or 20 millimeter. Then neoadjuvant concomitant chemo RT allowed 76% of the patient to retain the sphincter. So the answer lies between what Sharath Bhai and Kalai told. Even though the margin may be that of pre-op, in a upfront surgery for low rectal cancer who have not received chemoradiation for whatever reason, say T1 or T2 lesion to start with, not poorly differentiated in MRI, as per the Mercury trial did document notes, the margin currently accepted for well and moderately differentiated adenopia is 2 centimeter. What is the 20 millimeter? If it is poorly differentiated, it is much more. You all know that. But the same margin as for the MSKCC rectal cancer neoadjuvant trial 1 and trial 2. There are total 796 patients, which showed 70% can be sphincter. It is acceptable in well to moderately differentiated in distal margin of 2 millimeters. So if it is 2 millimeter distal margin of well modification, so what is the answer? Even though it may be
surgery margin like what Sevenbai told and what Kalyan told. The margin from 2 centimeter, it is acceptable to have 2 millimeter negative margin. So you are able to do orthodonty. So in exam, this is exactly the answer you have to take. But however, three of you stated spectral complex was inside it. No amount of chemotherapy can allow you to do spectral preservation unless you follow Abraham of observation weighted loss policy in case of critical CR. Pathological CR because after you operate it will
Not no, that's an answer which lies. So am I okay to put it this way, Sharat Bhai and Kalai?
Yes, sir.
Yeah,
Yes, sir.
see,
I think
basically many practical aspects are there involved rather than just fixed mindsets. So many times we tend to do ISR more because avoiding a colostrum is very important for human life, the quality of life. So we try to push in and extend our indications as much as possible. And see, again, it depends on the mass of the tumor size and all that. So just like in head and neck, wherein if you have a larger tumor size, so you need to have a little larger margin than the 2 millimeter margin, as you mentioned. When you have a very superficial lesion, very small lesion, probably you will get away with very smaller margins.
Good.
I think the point which you have mentioned also, that's important, like when the sphincter complex, so there you need to be wary of doing an ISR even after good response because you don't have a definite way of documenting. But for the mural margin, that is a mucosal margin, at least you can actually, even if you want to you can do a kind of a TAMIS, take a mucosal biopsy even before making sure that whether you want to do ISI in those cases. Probably that difference, like involvement of sphincter complex versus the mural extent, mucosal extent.
Absolutely. So remember also,
It
is not just distal margin. Craig et al. Trial showed a circumferential resection margin of less than 2 millimeter at the lateral end is thought to be positive margin, has the same chance of lateral wall pelvic recurrence as that of margin positivity. Kalai, for the benefit of surgical onco DNB students, what is the difference between ultra low LAR, LAR and intrasphincteric? Because we always ask this in exam and poor students always suffer. Can you tell what is an answer there to say what is the difference between ultra low LAR, LAR and intrasphincteric in exams?
Yeah. Yes, sir, that's a frequently asked question. So I think we all know we call it as anterior resection because there is also something called posterior resection. You must have seen in pediatric surgeons use the transcoccygeal approach or transsacral approach to access the rectum. That's why it is called posterior resection because we normally use the transabdominal approach. Like we are going through the anterior abdominal wall. That's why it is called anterior resection, which means the anterior resection, the line of transection is at the rectosigmoid. Now,
a very useful thing I want to pass, Kalai students, remember, people always ask anterior resection. Why anterior resection? Remember, it is in relation to the anterior to the presacrum. Because we also know when you do a transanal local excision for T1 lesions, there are 3 other approach. Cross case posterior approach, lateral approach and sphincter approach. So that's why it is in relation to your coccyx and sacral hollow, your anterior or your posterior or your side. That's why it is anterior. That's a very important thing what Kalai brought, always asked in exams. Kalai, please proceed.
Yeah. So now that's called the difference between the high and low comes the level of peritoneal reflection. So once you go below the peritoneal reflection, your dissection goes below the peritoneal reflection and you are doing the anastomosis, that's called low anterior resection. And if you are not opening the peritoneal reflection on the anterior aspect and the anastomosis lies above the peritoneal reflection, then it's called the anterior resection or the high anterior resection. Now, the difference between the low and the ultra low. The low anterior resection, you are actually doing the anastomosis below the pattern reflection, but you are not removing the complete rectum. So this is usually done when the tumor is in the upper rectum. So you can actually have an adequate margin without doing a complete excision of the rectum, which means there's some amount of rectal cuff is left behind in a low anterior resection. So it is a colorectal anastomosis. Now, in a ultra low, so strictly ultra low means you are going till the level where the mesorectum ends. So we will be going in the mesorectal plane, and then we'll be approaching close to the anorectal junction, and you will see the mesorectum ends, which means you are doing a total proctectomy. So a complete removal of the rectum and the mesorectum. So the anastomosis lies right at the level of pelvic floor. So it's an ultra low anterior resection, and strictly speaking, you should call it as a colonal anastomosis because you're doing a complete excision of the rectum. But the difference between ultra low and ISR is you are not entering into the intersphincteric plane. You are doing the dissection where the mesorectum ends. We are reaching at the pelvic floor, stapling right at there, which means you are doing a complete excision rectum. You are not entering the intersphincteric plane. So that's the difference between ultra low and the intersphincteric resection. So if you can remember these differences, you can clearly answer the questions.
Super. For intersphincteric. For a student's benefit, we read about all the sphincter, the nerve preservation. I always believe it is not the superior hypogastric plexus, but the inferior hypogastric plexus, which is formed by nervi laryngitis, and the lateral hypogastric. Inside the PLPF, overlying the fascia of the internal iliac vein before they form cavernous nerve is the most important nerve complex, which should be preserved for a ISR sphincter to work. What is an ideal patient for an ISR selection?
So the ideal patient would be the tumor is juxta-anal. So that's, I think, one of the classification you mentioned is intra-anal, juxta-anal. So the low rectum or the juxta-anal tumors without involvement of the sphincters. That means, I mean, you can have the internal sphincter involvement that up to the circular muscle or maybe just longitudinal muscle, but not into the external sphincter. And the patient should have a good sphincter tone, and the tumor should be well or moderately differentiated. So these are the group of patients, and they should be well motivated because they are going to have Lars syndrome, almost all of them. So it should be a well motivated patient to understand what will be the realistic outcome after ISR. And these are the patients whom we can select.
So that is fantastic. Typically, a young male whose sphincter manometry pre-chemo, post-chemo are absolutely fine. Sphincter tone is fine. And the sphincter you are able to preserve, because remember in ISR, everything is based on the external sphincter. So typically a young male with a good sphincter tone left behind after chemo radiation, which needs to be ideally analyzed by manometry before you operate, which rarely most of them do, are an ideal candidate. I think all good things has to come to an end. I would probably want to end with last one question from Sharad Bhai and Kalai. All the patients who have ultralolar intersphincteric, first 6 month life is miserable. It works like a perineal colostomy and a hurry, even though sphincter is there. I always tell my patient, they come and say, I have diarrhea. We say it is not diarrhea. The stool is formed. It is a increased frequency in Lars syndrome. What are the steps which we need to take to prevent Lars syndrome? I would want you to classify it into pre-surgery, during surgery, post-surgery. So Sharad Bhai and Kalai, before you plan to operate, the modification we need to do pre-surgery, intraoperative and post-surgery to prevent Lars syndrome for the benefit of student. How do we go?
Basically, carrying on from what Dr. Kalai said, basically the patient has to be motivated. Motivated in the sense that he has to be well informed of all the benefits which he is going to get with ISR. Many people just believe that the results will be similar to anterior section, which is not so. There are some deficiencies going to be there, especially some amount of continence is going to be affected. So that and plus the effects like diarrhea. Sometimes there's some mucosal leak causing a lot of scratching and irritation. Sometimes a small amount of incontinence, which is very common after ISR compared to LARs. Now coming to intraoperatively, as you really rightly mentioned, you have to be very particular in trying to preserve the nerve plexus lower down as much as possible. So you have to select patients, especially where you don't have to go too wide on both sides. That would be my main concern during surgery. And post-op is definitely the training that you will have to really concentrate about the food part, the acceptance part. Some patients are trying to use some diapers and all that in the beginning to prevent the mild leakages and fecal continence. Then over a period of time they recover. And there is a question about how I really don't know. We try to tell the patients about perineal exercises, but I really don't know how much it really helps.
Okay, Kalai?
Yeah, yes, sir. I think most of the points sir has covered. Just want to one additional thing which we also, tell in some patients who are troubled by this LAR syndrome is in the morning we'll ask them to give something called total colonic irrigation, like enema. So we ask them to do it in the take the morning. So that to some extent actually helps. It clears the colon and they usually, and then we ask them to wear like this. We especially tell them someone like teachers who have undergone these procedures. So they're always concerned about this seepage happening. So we ask them to take colonic irrigation in the morning and then wear a diaper. So that actually gives them a confidence and does help in some patients.
Absolutely. There is a beautiful paper on LAR syndrome. Please read it. Pre-operatively, patient should start a perineal exercises, which you do in a postpartum exercise in a woman. There is a set of exercises pre-op. Intraoperatively, please don't do dot dilatation. People have this habit of 2-finger dilatation to pass the anvil. The moment you stretch the sphincter, LAR syndrome is 25% more. The anvil of the circular stapler, if you are using in LAR, remember that itself causes. That's why Hansian anastomosis without the head of the anvil of the circular stapler is very important. Now preservation, number 2. Number 3, the type of the radiation given, short course, long course, duration of radiation and the surgery, 6 weeks, 8 weeks also matters. And post-operatively, as it told, there is a randomized control trial published 6 months back. Colonic irrigation in the morning and anti-5-HT, anti-5-serotonin inhibitor tablets 2 times morning, afternoon, evening, 2 tablets for first 6 months is statistically significantly known to cause that. Remember that particular anti-5-HT is not available in India, but you'll be surprised to know this Emiset, ondansetron, is an anti-5-HT3 inhibitor. And diet modification, these are the factors which really help. There are pre-op, intra-op, post-op factors. There are total 12 factors which prevents it. Please go back and read. But by the end of 6 months to 12 months, quality of life is same. Thank you very much. This topic cannot end, but my heartfelt thanks to Sharad Bhai, my senior, whom we all in GCRI greatly respect, and Kalai and Syed Shujaf. Superb job you did, man. Very good. I had to borrow your slide for my teaching eternally. Thanks Kalai, thanks Sharad Bhai, all good things has to come, and thanks Navneet Singh ji patiently allowing us to overshoot. We need to deposit some money to DNB board for overshooting all the time. But a great discussion. Thanks all of you. My heartfelt thanks to both faculty on behalf of students. We can only give blessings to you from NBE board, and thank you very much.
Thank you, sir.
Thank you so much.
Thank you, everybody.
Thank you very much, Dr. Syed, for the presentation, and thank you very much, Professor Raja, Professor Dr. Sharad Desai, and Professor Dr. Somashekar for joining us. And thank you, trainees, for joining us.